Okay, in this video we're going to have a look at Lockie. Lockie's presented with some back pain and some right posterior thigh pain that's come on with footy training. Hasn't had an incident, hasn't had an episode where he's actually torn his hamstring or anything like that. It's just been a vague, achy sort of pain in the back of his leg, aggravated by running and some kicking. What we're going to do is basically go through some of the objective assessment and treatment sort of stuff. But again, when we've got someone presenting, we want to understand their red flag sort of things. So asking about whether you've had any significant night pain, have you had any unexplained weight loss, have you had any pins and needles or numbness in your legs, have you lost any strength in your legs, have you had any trouble with walking or feeling uncoordinated with your walking or standing? No. Okay. So we're going to have a look at Lockie's posture, do some observation, then we'll have a look at his range of movement, do some special tests, and then we'll also have a look at doing a palpation assessment and working through some clinical reasoning as to what we do for treatment. So Lockie, if you don't mind taking your shirt off to start so we can have a bit of a look at your spine. So if you can stand up and you can face this way, I'm just going to come around the other side. So just come forward a fraction. So hands by your side, feet just comfortably apart. We're looking at general posture, looking at alignment of the spine. So running your finger down the centre of the spine and seeing whether there's any deviation, any scoliosis. Putting our thumbs onto the PSIS there and just seeing whether they look level. Fingers into the side and just looking at the height of the iliac crests and seeing whether they look even, and everything looks pretty even there for Lockie. Looking to see if someone's got a significant lordosis or a flat back. Lockie's got a little bit of a lordosis. He certainly hasn't got a real sway back posture, and he's certainly not extended there or just posturally tilt there the other way. So he's not got that really flat back posture, so just stand comfortably again. So he's got a nice lordosis there. Look, his thoracic spine is not really kyphotic. His scapula are in a reasonably good position there. You can look at muscle bulk as well, so looking to see is there a significant increase in bulk on one side compared to the other, and then getting a general view, like even looking at the shoulders, do they sit level? Is one side more dropped than the other side? You can look at the inferior angle of the scapula there to also determine whether their spine is straight or deviating one way or the other. Probably, if anything, that Lockie's a little bit more developed on that right side compared to the left side in his lumbar spine there. So Lockie, do you mind just bending forward and down, seeing if you can touch your toes there? And we'll just have a look at your lumbar range of movement. So Lockie's put all of his knuckles down to his metacarpals there onto the floor. Come back up. Any pain doing that, Lockie? Okay. And now going backwards and arching backwards. Okay, how does that feel?
Yeah, a little bit
sore. So he's a little bit stiffer in that direction, and it's reproduced some of his pain. So just show me where you felt the pain there. So right sided. Yeah. Okay. Can you now, hands by your side, lean across towards the left and reach down as far as you can towards the side. So, and we can measure there, come back up again. So he's a few centimetres below the popliteal crease. You go to the other side. So on that side he's probably just at the popliteal crease, so there's about 4 centimetres difference. How does that feel when you go to the right side?
A bit of pain there.
A bit pain on that side. Just go to the left again for me. Just going to have a look there. I'm just looking at the line of the spine. Go to the other side. Yep. And so there's not as much of a curve when he goes that side, so more restricted going that way. Lockie, can you ever sit on the side of the bed for me now? And just move back so that you're fully supported. Hands across your chest like that. And I want you to just rotate towards the left for me. Any pain when you do that? And because he's got no pain, I'll add some overpressure there and go the other way. Any pain doing that? Okay, so what about when I do that? Yeah. Okay. Quite often if someone's got restriction on lateral flexion, they'll often have restriction on rotation as well, but again, you go with what you see. Because Lockie's had some pain down into his hamstring, not the sharp shooting pain, the vague achy sort of pain, I would probably, just as a quick assessment, do a slump in this position as well as doing a neurological test. Again, you could go and do the lying down prone stuff and then get up and do it, but whilst he's sitting here, it's really easy to just go into doing a slump test. So, like, if you can put your hands behind your back, no, just let me talk you through it. Hands behind your back, tuck your chin down to your chest. Any back pain doing that at all? For some people, even just that cervical component can bring it on. Slump down for me now. Okay, any pain doing that? Okay, and straighten that right leg for me. Any pain?
A little bit.
Yeah, and pull your toes up towards you. Any pain with that? Yeah, just lift your head up. Does that change the pain or take it away? Yes. Okay, so bring your head down again. Okay, now just straighten your left leg for me. Any pain doing that?
A little bit.
Yeah, compared to the other side?
Not as much.
Yeah, pull your toes up. How's that?
Yeah, a little bit worse.
Is it the same as the other side or different?
A little bit. It's not as painful.
Yeah, so it's a little bit worse on that side. So we've got, I mean, Lockie's wound up really well there. So, and you could see that when he did his flexion test, he could touch his knuckles to the ground. So flexion and tension within his neural structures is not a massive issue, but it's slightly different on his right side to his left side. So we can actually, when he's fully wound up, it's a little bit tighter on that side to the other side. We can use that as an asterisk sign. Lateral flexion to the right, we're going to use as an asterisk sign. Extension as an asterisk sign. Flexion, there's no point reassessing that because he's already pretty full there, and his rotation didn't reproduce any pain. So we've got a few things there, a neural test. Now we can also assess his his straight leg raise. So just come up onto the bed there, Lockie. Rest your head on the pillow there. Again, I always put a pillow on because it makes people comfortable. If it's reproducible, using the same position each time, then it's fine. But if you do a straight leg raise and you've got a pillow there 1 minute and then you reassess it without the pillow there, with their head sitting in the hole, that's going to influence the neural structures. Often you should do the left or the unaffected side first. How does that feel, Lockie?
Yeah, just tight.
Just tight? Yeah. If you want to add in some neural tension, you can also do that. And also adduction. Lift your head up off the pillow. How does that feel?
Yeah, very tight.
Yeah. With some people that have got hypermobility, sometimes when they lift their head off, it actually makes it feel better rather than worse. So yeah, you don't always. Sometimes you expect to get an increase in symptoms when someone adds in cervical flexion, but for some people that they actually feel better when they flex. How does that feel?
Yeah.
How does that feel compared to the other side?
Yeah, a lot tighter now.
Yeah. Okay. So again, there's not a lot of difference in range between sides, except that it feels tighter on that side than the other side. Okay, so we've done our range of movement, we've done our observation, we've done our nerve testing. We could do a neurological examination because he's got pain below the hip. I'm not going to do this, we'll do this in another video. But yeah, like if you had someone with sharp shooting pain or nerve symptoms, like a numbness or a tingling or a pins and needles, you'd now probably go on and do your dermatome and your myotome testing. We're going to get Lockie to come over onto his stomach so that we can do some palpation of his lumbar spine. At this stage, I'm sort of expecting or thinking that there's a joint or a musculoskeletal reason for the restriction that Lockie has and maybe contributing to his pain. So if we get him in prone, are you comfortable in that position, Lockie?
Yeah.
I'm just going to bring him up to the point that is good for me. What do we do with the towel? Yeah. So quite often, again, just as a way of draping the patient and making them feel comfortable, I'll use a towel, tuck it in under there, and then if we then get our surface anatomy markers, so if we come onto the PSIS there, we know that that's going to be level with the sacrum, and then we come a bit above that, we're going to be sitting around about L5. How does that feel, Lockie?
That's okay.
Yeah, and then working our way up the spine. So as I palpate, I'm pressing in gently to start, and then gradually getting deeper, working down, using that pisiform grip with the base of my hand, and working my way up the spine. How does that feel, Lockie?
Yep. Okay.
Yep. So centrally, look, I'm feeling that there's a relative tightness or stiffness, and probably a bit stiffer down at that lower segment of the lumbar spine. If I then come out from L5 out laterally, so again, just feeling where you can drop off the back of the pelvis and the top of the sacrum there into that little gutter where you know that you're going to be over L5. How does that feel in there, Lockie?
A little bit sore.
And I can feel a bit of guarding there, a bit of muscle contraction happening. And I'm just going to work my way up the spine, asking Lockie how it feels as I go up through each one. So I want you to let me know, Lockie, if when I press in here, does it reproduce your pain, the pain that you've been feeling when you've been running and doing your football training, or even the pain you're feeling after training or during the day? How does that feel?
Probably that L5 right side.
Yep, right in there. Yep. And again, to make sure I get an understanding of what is relatively normal for Lockie, I'm going to compare it to the other side. So I'm going to work my way through again, starting off with just a bit of pressure, and then working my way up and down his spine through the 5, 4, 3, 2 facet joints. Also getting a general feel for what are the muscles, what are the erector spinae muscles like, what's quadratus lumborum like in that area. Did any of the movement or pushing that I'm doing here reproduce any of your pain down into your thigh, Lockie?
No.
Okay. So in assessing even further, the things that can cause pain to radiate down into the thigh can be structures in the lumbar spine. You can also have structures in the buttock or the hamstring itself that are reproducing pain. What I'm going to do now is to just get a bit of a feel for whether palpating Lockie's piriformis or his gluteals is recreating any of the pain down there. So if I feel on the side of his hip there where the greater trochanter is, understanding that the piriformis is going to go over into the base of that, again getting a general feel for where the sacrum is, just from my knowledge of surface anatomy. The line there from about the mid sacrum across to the posterior part of that greater trochanter is going to be where piriformis is, and we know that the sciatic nerve comes either above, below or through that piriformis muscle. So how does that feel as I press through there, Lockie?
Yeah, that's the spot.
Yep. Okay, so does that create any radiation down into your hamstring or reproducing your pain at all?
Yes.
It does?
Yeah.
Okay. Is it worse as I come out to the side, or is it more back?
It's more,
More in
in
there.
the middle.
Okay. What's it like down there?
It's not too bad.
And there?
That's fine.
And as I come around into the side of your hip there?
Just a little bit tight, not the same pain though.
So ideally what we're trying to do is trying to identify, so I'm working around in there, my knowledge of anatomy, you've got your gluteus medius, you've got your gluteus minimus and your glute max, so getting a feel for where potential trigger points within the muscles are that can radiate pain down into the into the buttock or into the thigh. It seems like when we press in that region of the piriformis, and I mean, is it the piriformis, is it the sciatic nerve? We're not 100% sure, but we know that that has reproduced Lockie's pain. In terms of treatment, do we just go straight to where Lockie was feeling the pain, or do we work on things that could potentially be influencing pain in that region? Is it local pain here that's then radiating to there? Is it the influence that the structures in the lumbar spine or the buttock or even into the hamstring itself? If I press in the hamstring there, does it actually reproduce any of your pain?
No.
Okay, so is there any tenderness there within
No.
the hamstring?
No, there's none.
Yeah. Okay, I might also do a resisted test of the hamstring, so just push up for me, Lockie, against there. Any pain doing that?
No.
Okay, so if it was a true hamstring strain, you would expect that Lockie, when we stretched his hamstring, it was painful, and it was also it would also often be painful when he actually resisted, did a strong contraction of that muscle, which that didn't do. The other thing that we can do in this position too, if we're suspicious of piriformis, because piriformis, when it contracts, it will rotate the hip externally. If we bring Lockie's knee up into this position and we externally rotate the foot out, which is internally rotating the hip, does that cause any pain or tightness, or
A little bit of tightness.
yeah? Where do you feel it?
So,
In there?
It's also
Yeah.
a little bit of impingement.
Yeah. Okay, and then we can do the same on the other side and comparing sides. So if Lockie was a lot tighter in terms of his restriction in his range of rotation, there was a lot different on one side, that would tell us that that piriformis, of those external rotators of the hip, are quite restricted. So in terms of treatment, what am I thinking? I'm thinking he doesn't have great extension, he doesn't have great lateral flexion to the right. That, I think, is a contributor. He's tight and tender within his piriformis there. I'm going to try to start to see if I can change the dysfunction within the lumbar spine by mobilising his lumbar spine. Now, is Lockie irritable? No, he can run and he can sprint, he can play, he can train at footy, but it's just irritating him or annoying him and stopping him from that high level stuff. So do we need to use low level grades of mobilisation or manual therapy? I think not. I think we actually aren't going to make much difference if we just go in and we use grade 1s or 2s where we're trying to treat pain. We actually want to get in there and mobilise quite firmly. How does that feel, Lockie?
Yep.
Yeah, and quite often, if it's a stiffness issue, people will say things like, yeah, look, that feels good, it hurts but it feels good, or it's actually, yeah, that's on the spot, I can feel that's really tight there. So mobilising in there, so I'm just going to do a couple of minutes of mobilising, and you can see that I'm pushing quite vigorously there. I'm coming in and out though, so I would say that's a grade 3 technique. Maybe if I push a bit harder, I'm getting into 3+. So grade 3 or grade 4 at 50% of resistance is going to be how you would classify a grade 3 or a grade 4. If you go into 75% of resistance, where you're going firmer, that's a grade 4+ or a grade 3+. And if you're going into 100%, so you're really getting in and you're going as hard as you can, you feel like you're going into full resistance, then it's a grade 3 double plus or a grade 4. Like 4, you're sort of in there and you're bouncing very lightly in and out. Grade 3, you're sort of doing a much more larger grade, a larger amplitude of movement. Okay, so let's say I've done 3 or 4 minutes working on, look, I've worked through L3, 4 and 5, more around L4 and 5. Come and stand up again for me, Lockie. I'm just going to reassess. And what are the movements I'm going to reassess? First thing is going to be extension and right lateral flexion. So standing up, Lockie, and just turn around and just arch backwards for me. How does that feel compared to before?
A lot better.
Yeah. So is that truly better, or is that just for the camera?
Yeah.
Good. Okay, go across to the side for me. So again, before we got to the popliteal crease, whereas now we're getting a few centimetres below. Just go to the other side, just as a comparison. Yeah, and so he's getting about the same as he was on that side, but he's now going further that way. So just come back on the sitting position. So the third thing that we could use as an asterisk sign was that slump test. And Lockie's range of movement was good, but his description was that it felt tight. Let's just see whether it still feels tight. So hands behind your back, tuck your chin to your chest, slouching down for me, straighten that leg. How does that feel?
Not that bad actually.
Pull your toes up for me. How does that feel?
Better, but still there.
Still there, okay. So that's better, but still there. I'd say that maybe mechanically we've changed some of the restriction within Lockie's lumbar facet joints, and his lumbar spine's moving better. Let's get him back on his tummy now. So my clinical reasoning now says I've addressed the lumbar component to this and I've improved the movement and it already feels a bit better. His slump still feels the same. I found when I was doing my assessment that he was tender and tight through his piriformis. So I'm going to choose a treatment technique where I use ischemic pressures. So you can use either your thumbs or your fingers. How does that feel, Lockie? Does that feel like I'm on the spot there, or do I need to go down or up or in or out?
A little bit higher from that. That's
A little bit higher?
Yeah, that's
Yep.
it.
Yep. Is that reproducing your pain down into your hamstring? Okay, so if we get on the spot and we're reproducing symptoms, give me a number out of 10.
4.
4, yep. Okay, so when it's at its worst, what would it be out of 10 that you get down there?
6.
A 6, okay. So if I can have some reproduction of his symptoms up to 4, like 4 or 5 out of 10, I'm thinking that's on the money. If I'm pushing that hard that he's telling me that it's 8 or 9 out of 10, then maybe I'm more likely to do irritate or aggravate the symptoms than help it. So I'm just going to use ischemic pressures like that. Just pressure like that can be enough. If you've got someone that's relatively non-irritable, so, and that's the category that I would put Lockie in, and look, if he feels really tight, you might use your elbow. How does that feel? Does it feel like I'm on the spot?
Yeah,
and then again, if I bring Lockie's foot up, and with that pressure, I then do a small movement of internal and external rotation. I'm just going to grab your ankle so you don't drop your foot. So you want to be just gently rotating in and out. So that's stretching that piriformis whilst I've got pressure on it. So it's a bit like massaging, so you're moving the muscle underneath my elbow rather than moving my elbow backwards and forwards over the muscle. Does that make sense?
Yep.
Okay, so again, a few minutes of that sort of work. Just come up and sit up again into that sitting position. Just put your hands behind your back again, Lockie. Tuck your chin to your chest, slouching down, straighten that leg, and then pull your toes up. How does that feel compared to before?
Better.
Okay. Yeah, so sometimes you can make a significant change with not a lot of force and not a lot of pressure. Like, do we need to do manual therapy for 30 minutes of the consultation, or can we make a significant change? If we can make a significant change within a few minutes, like I did with Lockie's lumbar spine, if there wasn't much change there, I might then go back and go with a heavier grade or do more. Or if I've only improved a little bit, but I've made an improvement, my clinical reasoning says let's do that technique again. You want to keep it fairly simple, but if you've made a big change and you've addressed your range of movement thing in the lumbar spine with that first technique, but then, like I found with Lockie, that hamstring was still sore or he felt that tightness when we did that, let's go for what we also found in our assessment. So sometimes you will only focus on one thing in a session. Sometimes if you've made a change with one, you can then go on to the next thing. If someone's really irritable, you're much more likely to say, choose that one thing, choose the lumbar spine thing, and then let's go away and then review it again in a few days. What are the go-to exercises that I would have Lockie do? Well, let's go back a step. Like if the unilateral treatment technique of MOBs didn't make a significant change, I might then look at using a rotation technique. So with Lockie, if I decided that I'd want to do some rotations to impact that right side, I would get him on his left side. So come on your left side over there, Lockie. And again, he's not very irritable, so I'm going to wind him up a fair bit. Like, just come back a bit, Lockie. If Lockie was pretty irritable, I might start off with just doing some really simple rotation where you're trying to open up and rotate. Generally, you're trying to rotate away from the side of the pain, so we're rotating towards the left side here for that. So just that sort of technique there, or even like that, is a nice way of just sort of trying to relax. And then if you bring this shoulder through, bring your hands just onto your rib cage there, Lockie. Again, depending on where I want Lockie's lumbar spine to be, I'll adjust that bottom leg, and I'm going to start off with Lockie's foot just tucked in behind his knee there. So hands on the rib cage there, he's pretty wound up, and then I come in, my hands there stabilising his trunk, and then my driving force is basically coming through this hand along the line of the femur there. How does that feel, Lockie?
It's a nice stretch.
Yep, so it's a nice stretch. And then I can do again my grade 3 or grade 4 mobilisation technique there. If you look at how I've got myself positioned, I'm able to be in line with where I'm pushing. I'm stabilising through my, this hand's pulling back, holding there, and then I'm driving through there, but I'm pretty much rocking my body rather than pushing my arm. So what I don't want to do is lots of rotation and flexion with my spine. I want to be basically doing the driving. I'm pushing through my back leg and I'm lunging onto my front leg. Now, if I want to add a little bit of extra there, if that's feeling quite good, I can bring Lockie around there into not a straight leg raised position. That's going to put his hamstring and his neural structures on a little bit of stretch as well. So as a progression, and you might do this not day 1, but you might do this day 2 or day 3 if you're feeling like you're not getting exactly what you wanted in that first treatment technique. So again, you would do it in sets of say 30 seconds with your mobilisation technique. You use your clinical reasoning to determine whether you go with a grade 3 or a grade 4 or a grade 3 plus or a 4 plus based on how they're responding and how they're feeling, looking at their face, making sure that is that influencing their pain? Are they getting a significant increase in pain? You've got to back it off. Is it a good stretch? And they'll often tell you that. Then you work with them to take it to the grade that you feel is going to make a difference. Then come and stand up again, Lockie. Again, let's have a look at extension. So arching backwards for me, yep, and back, and then go sideways for me. Now, I'm reassessing those ones again. Sometimes you'll do a technique and the person's symptoms will actually get worse again. So sometimes that information, like if we go, oh, we looked at that changed before, we don't need to look at that again. Have a set on the side of the bed. So you're getting towards the end of your treatment session now. Hands behind your back, tuck your chin to your chest, slump, and then straighten that leg for me and pull your toes up. How does that feel?
Still the same.
Yeah. So a little bit tight?
Yeah.
Yeah. Okay. How does it feel compared to when you first came in? Yeah. How much better? Can you give me a percentage?
Probably 40% better.
40% better? Good. I'm happy with that sort of amount of change within a session. And then what sort of exercises would I then send Lockie away with? I want to give him something that reproduces what we've done in our treatment. So if I've used a rotation technique like that, what would be the best stretch to give Lockie? Lie down on your back, Lockie. So you can do this on the floor or on the bed. Come a little bit further over to the edge here. I want you to straighten out your left leg to bring that knee up, and I want you to rotate across that way. Use that hand to put on your knee there. When you get to there, I want you to breathe in and breathe out, and I want you to just try and guide and pull that knee across that way. You should get a stretch through there. If you want to increase the stretch on that thigh a little bit, you can straighten that knee out as well. All right, I want you to do 2 or 3 deep breaths and then come back to the middle. So it's going to give you a stretch for 10 to 15 seconds, and you can do 5 or 6 of those 2 or 3 times a day. It's a good one to do at the end of your training session. Before you go out, we tend to do more dynamic stretches, so I want you with your feet together to just rotate from side to side. So again, this is a nice one that you can do just to try and increase your range of movement just in rotation, and as a warm-up. This is going to be sort of a loosener, and then the other one where you'd hold is going to be more of a stretch. All right, so that would be my priority stretch. The other thing, and because Lockie has done it quite a few times already, just come and sit up again. I'd also like you to do what we call a nerve gliding stretch. So if you tuck your chin to your chest, hands behind your back, so like the test we did earlier, come down into a slump position. Now in that position, I just want you to move your foot up and down 5 times. Keep your toes pointed. So we don't want to take it up into a really wound up sort of a stretch. So you're holding the top end into tension, and then come and sit back up straight again. All right, and you might repeat that about 3 times. Again, it's a good one to be doing a couple of times a day as a way of just stretching out those nerve structures that run through your buttock. Yep. Look, if we found that the technique on the buttock worked really well, I mean, have we restored much of his rotation and his lateral flexion range there? We might actually choose that our treatment stretch is the piriformis stretch. So if you come on your back, Lockie, again, really only want to send them home with just a couple of things. Like if you give them too much, it's confusing. So I'll just show you, again, in this scenario, a piriformis stretch might be one of the things that you choose. You might choose piriformis stretch and rotation. We might leave the slump out, or we might say piriformis and slump and not worry about the rotation because his lumbar range of movement was actually pretty good. Or like if we're doing a rotation and we're adding that bit of a hamstring stretch by straightening the leg, then that's adding your neuromeningeal sort of stretch. So do you need to do the slump stretch? So there's lots of things that you can choose, and it's sort of going with gut feel a little bit as to what you think is going to influence things the most. So piriformis stretch, right side, foot on your knee there, the old pretzel stretch. If you can reach through with that hand between, you've got to grab this knee, grab there, or even in front of your knee. Hands through there, that's it. All right, and then once you're there, where can you feel the stretch there? Down in the buttock there, yep, okay, so that's good. And then with that elbow, you can actually push that knee, that thigh out a little bit as well. All right, so that's a really wound up piriformis stretch. If they struggle to get in that position, sometimes you try and get them to do that and they go, no, I can't even hold that position. You can just go with pull your knee to your chest and pull your knee across to your opposite shoulder. How does that feel? Do you feel that stretching down into the buttock there? Just not as strong. Yeah. So again, depending on irritability, you might go with that day 1, and then after a few sessions, you might wind them up into the full-on piriformis stretch. All right. Hope that gives you a bit of an idea about working your way through an assessment to treatment techniques to choose. You test, retest, and then review. That helps you to then make the decision about what do I do next. Okay. Most important things though, keep it as simple as you can. Again, I've shown 4 different exercises, and I only want you to choose 1 or 2 of those to give to your client on day 1, and then you might add another 1 or 2 as you go along in your next treatment session. Or you might say, okay, today I want you to keep doing this one and add this one, forget about that other one. I reckon we've achieved what we needed to with that.
Very good.